BG Dental Cases and episode number 7. First of all, I would like to thank everybody for watching us and to send us really nice and humble and pretty positive feedbacks about our projects. We are very proud and very motivated to continue this work, and our goal is to provide this free of charge dental education, discussing interesting clinical cases and giving you tips and tricks related to the dental approaches in dental fields in different directions. My name is Belograd, and we have got a lot of requests to provide clinical case review related to endodontic treatment. And today we will be speaking and we will be discussing with you endodontic case related to apical periodontitis. We will be discussing with you minimally invasive access, and also we will be discussing post-endodontic rehabilitation and aesthetic dentistry in one case. So that is pretty huge mixed dental case related to different approaches and different directions. We call it mixed fight dentistry, when endo, restorative, aesthetic meets together. By the way, if you're interested in that kind of dental way of treatments, let's say, or that type of dentistry, let's say mixed fight dentistry or advanced general dentistry, I would suggest you to sign up to our Module 4 from Endodontics to Restoration. This is our module course, hands-on course about endo, primary, retreatments and post-endodontic rehabilitation, when we do during hands-on a lot of multiple clinical exercises where you can get your skill upgraded in most efficient way, because we don't have any theory. It will be absolutely 100% practice and hands-on. You may find information about our courses in text to that video. Okay, so let's go. Also, I would like to say that starting from that point, we will do some interesting contests. And today we will do contest with prize. We will give free of charge participation to our online masterclass that is called Technical Aspects of Preparation. So, but you have to do something, okay? What you have to do, I will tell you right now. So let's just take a brief look to the initial situation. We have a patient that came to our clinic with a strong request to improve his smile. The appearance of his teeth was pretty, let's say, was not so beautiful, and he was so upset because of aesthetics, and also he was not happy because of the color of some of his teeth. Actually, 3 of them, these ones, okay? The reason why he was not so happy with that teeth is that they are endodontically treated and that they got discolorated after some time. So he asked us, can we solve this problem, especially the problem when he periodically has some sinus tract, okay? So the case was pretty difficult to start with, not just because of aesthetic outcome and endodontically treated teeth, but also because of the level of hygiene. And I can tell you that we spent a lot of time to motivate this patient and to educate this patient to take a good care about his dental hygiene. So the contest to win our online masterclass is write down in comments, please, your tips and tricks. How do you motivate your patients to do complex hygiene procedures? So write down answers. How do you motivate your patients to do dental hygiene in a really advanced way? And the best comment we will choose as the winner of our online masterclass, and we will define winner next Monday during live on our YouTube channel. Okay, so let's go. This is another view for that teeth. From the palatal side, you may see multiple or various composite fillings and caries defects, and here is our step-by-step endodontic approach. So as you may see, the central incisor is necrotic, that will be primary endo. And in this case, we decided to go for two-step endodontic treatment. The first step was cleaning and shaping. Then we put calcium hydroxide into root canal system, and then this open apex was plugged with MTA. And then we made obturation, and then we made coronal restoration, and then we end up with aesthetic treatment utilizing porcelain metal-free crowns. Perfect. So in this case, you can see some kind of old dentistry. It's like liners or cement liners, because sometimes people still used to think that composite material may cause pulp necrosis because of the toxic action of monomers, which is not true, because the modern composites, they are not toxic as like 30 years ago maybe. But since that time, we still have some kind of dental cases with that so-called protective liners as cements to prevent toxic action of composite materials. Both sides were the same. The cement dressing, and then open pulp, and then necrosis afterwards. I made endodontic access, which was absolutely defect oriented. What does that mean? Once I removed these composite fillings and cement dressing, the pulp chamber was already opened. So I just increased slightly the aspect of my access to remove pulp horns and to be able to irrigate this root canal system in an efficient way. So according to classic approach to do endodontic access, this is absolutely not correct one. But we can do this type of access in case if this access is not on your way to provide proper endodontic treatment. In other words, endodontic access has to be as big as you can go for root canal shaping, root canal irrigation, and root canal obturation. Okay, so this is the steps of endodontic treatment. In this case, root canal was straight, root canal was wide, and I was able to negotiate with this root canal even from that axis. So what I did at the very beginning, I just kept my axis as small as I could in this case, and then I started to negotiate with the root canal, and then I found out that this axis is not on my way to perform endodontic treatment in proper way. So basically, we decided in this case to keep this axis that minimal. We have tons of benefits to get this axis that minimal. Just imagine if we will have to do straight line axis, okay? We have to remove that amount of tooth structure to get this straight line. And at the end of the day, there will be no tooth, or let's say it will be a pretty big destructive case caused by caries defects and also caused by access formation. So in that approach that I'm sharing here with you, our endodontic treatment will be minimally invasive, and then if we will use metal-free ceramic restoration for aesthetic treatment and functional treatment, as in this case, we can also do minimally invasive preparation from outside, from inside and from outside as well. So this tooth will benefit from the minimally invasive approach. But what I would like to say, what kind of message I would like to share with you is, don't try to do super minimally invasive access in every single case. Access has to be driven by defect, and also access has to be driven by next step of endodontic treatment. So if you cannot go to the root canal, especially in curved root canal cases, because of the access you have to do straight line. Otherwise you may do file separation, you may perform ledge, and you may not complete endodontic treatment. So your access will be criminal one. In this case, everything was super simple. Another trick and tip that I would like to share with you is a trick how to irrigate in case when you have open apex. In this case, the apex was pretty huge one, and there is always risk that during irrigation process some amount of sodium hypochlorite, if you use sodium hypochlorite for irrigation as the golden standard. So sodium hypochlorite can be extruded through the root canal into periodontium. So there will be a pretty big risk, the high risk to get some toxic effect of sodium hypochlorite and some inflammation after extrusion of the sodium hypochlorite. So the way to eliminate this action is pretty simple. You may buy a specially designed device that is called ENDO system. ENDO system. I think it's from Cyber and Endo, if I'm not mistaken. So it's just a tube that is connected to your suction system, and then you put this tube into the apical third of root canal, and you inject or you rinse or you irrigate with your solutions starting from orifice. So your tube connected to suction system is in apical side, and then you insert your irrigant to the orifice, and it goes, because of the suction, to the apical third. In this case, there is no risk to go with sodium hypochlorite out of the root canal. And another benefit that you may get is that inside the root canal you get some kind of hydrodynamics. But this ENDO system is pretty costly. If you have that money to invest in that device, it's amazing. But if you would like to save something, you just take a really thin surgical section. Then you can take the tube or tip for calcium hydroxide dressing. This is the one from calcium hydroxide. So you put this tube to your suction system. Then you put this suction into the root canal. So this tube will be in apical part. In this case, when the root canal is pretty wide and straight, it's easy. And here you can see that we can irrigate starting from orifice, which is simple. I would put this calcium hydroxide needle, like you can see now. This calcium hydroxide needle is in the root canal, in apical third, in working length actually, and I'm just injecting my sodium hypochlorite from orifice, and all this irrigant goes to the apical third. We get some hydrodynamics, there is no risk of over extrusion, and everybody is happy. And the good thing also is you are doing stressless dentistry. So look, this is the view for access after endodontic treatment was finished. Pretty nice, tons of enamel preserved. The tooth is happy, as you can see here, because we have tons of sound tooth structure preserved, and in this case we don't need to put post, we don't need to do some extra retentive preparations, because we have dentin and enamel to be bonded to. And considering the fact that we will be using metal-free ceramic restoration, we can do a really conservative preparation as well, like 0.3, 0.5 millimeters only, and you can keep enamel around and everything will be bonded. So you don't need to make some aggressive treatment just for tooth reinforcement by the post or whatever. The process of obturation was pretty simple also. We put MTA after calcium hydroxide removal. We put MTA. There will be very soon another issue of our BG dental cases. I think it will be next or after next one, the case review, where I will be showing you step by step performance with MTA. So during that case, I will explain you and will show you the way and tips that we use to dress MTA and to plug our MTA in the root canal. So during that case that you are participating right now, we will be not spending time, okay? So then we have placed mocap, because this mocap was driven by our smile design project. At the end of the day, this patient was about to do aesthetic treatment, not just ninja access. So we made a treatment planning, okay? We made wax up driven by the mocap, then we prepped through the mocap, The depth of preparation was driven by dental technician's request. In this case, we changed the color, and you have to ask your dental technician regarding the thickness of material that he has to change this color. So your dental technician will have to give you some numbers. For example, if you have A3 and you want to transfer A3 into A1, you have to give him 0.5 or 0.7 or 1 millimeter. It's up to your dental technician. You have to ask your dental technician. It's not like you just prep and then you send impressions to your dental lab and then you say, please do your best. That way does not work properly. You can guide your dental technician regarding shape that you want. You can guide your dental technician regarding the length of teeth that you or your patient wants according to the smile design projects. But regarding the thickness of preparation, your dental technician has to give you numbers. If you guys are interested in this topic, I would suggest you to attend our Module 3, which is course about porcelain veneers, hands-on course from A to Z, from treatment planning, from smile design, from dental photography, for mock-ups, preparations, isolation, and bonding of porcelain veneers. This is what we can teach you, and after this course, you'll be able to do veneers with strong confidence. Okay? For those who cannot come to our place, I don't know why, because actually we have already been visited by participants from 77 countries, but anyways, we also have online masterclass about aesthetic treatment planning. You can find this online masterclass in text subscription to this video. Okay, so we made these grooves. Okay, we made these grooves, then we removed mock-up, and now you can see how far we went into the sound tooth structure. So in this case, pretty minimally invasive case. Then we prepped. This is step 1 finished. We finished step 1, and then in that case we had to replace old composite fillings that this patient had. That's why we placed rubber dam. Okay, we placed rubber dam to remove old fillings, to fill these cavities with a new fresh composite, and to prevent leakage, to prevent bleeding, and many other things. So we get this rubber dam for that procedure, and then we took advantages to prep with rubber dam. So basically, we finished step 1 of preparation before placing of the rubber dam. Then we placed rubber dam, removed filling, put the new ones, and then we finished our preparations with rubber dam on. And it is pretty comfortable to prep with rubber dam because you don't have any soft tissue exposed, no bleeding, no saliva. Your patient is not asking you questions. You have tons of light because there is a proper light reflection. You can be concentrated on the process of preparation. You have amazing contrast to your eyes when you prep teeth with rubber dam. I'm not trying to say that I'm placing rubber dam all the time to prep. For frontal teeth, we can prep with Optrogate, for example. But if you have endodontic treatment and then you prep, or you have to do some fillings and then you prep, you can take this advantage to prep with rubber dam, and you will enjoy. By the way, I would like to ask you, please write in the comments also who preps with rubber dam, who uses to prep with rubber dam, and your your feedbacks, your feelings. How do you feel it to prep with rubber dam? Do you like it, or maybe you tried and you don't like? I would like you to ask kindly to give me your feedbacks about rubber dam preparations with rubber dam, because we're collecting some statistics for another educational projects. Okay, so this is the final view of prep teeth. Then we took impression, and then after a few weeks we are about to bond our ceramic restorations, and these are teeth after we removed provisional restorations. You can see the conditions of soft tissues. The dental hygiene was pretty okay, so you cannot see some big inflammation, which is really good. You can see also the macro picture with enamel preserved. In this case, I made finish line about 0.2, 0.3 millimeters. I would like also to give you some important message, because using microscope or using loops, we can do that type of finish lines like 02, 03. But you have to do that type of finish lines only in case if your dental technician is able to give you proper fit. Because be honest, we can do 0.1 finish line with microscope, it is not that difficult. But if your dental technician does not give you proper fit of restoration for that type of preparation, it makes no sense. So you have to cooperate with dental technicians, or you have to force your dental technician also to use magnification or microscopes. And to be honest, the cost of microscope for dental technicians is not the same as microscope for dentists. So when some dental technicians complain that microscopes are pretty expensive, it is not truth. It is not truth. Maybe it's because your dental technician doesn't want to get out from his comfort zone. That's why. And we can compare, by the way, the old approach to prep for the crown and the modern approach to do this full contour ceramic veneers or crowns. Actually, they are crowns. Okay, but you have to cooperate with good dental technicians to get this fit for such a minimally invasive preparation. Now you can see how these teeth look like before cementing, before luting of ceramic restorations. Now you can see fit, dry fit control, which means this is picture that was taken before cementation, because I saw a lot of cases when dentists and colleagues, they show fit after cementation, and it doesn't give any information, because after cementation every single margin will be filled with resin composite. So you will be not able to see any defects. So dry fit control really shows you the real data, the real information about fit. Okay, so this is another pictures before cementation, and these are picture after cementation and after some period of time. In this case, we have 6 month follow-up before and after. I will show you some x-rays also. And what I was really proud of is that in this case we were able to transfer pretty dark teeth like A3.5 into BL3 as patient requested, and dental hygiene was pretty good within these 6 months. So I'm pretty proud of my team, not just from dental aspect of workflows, but also psychological workflows, that we were able to send message, to deliver message to the patient, that patient is responsible for long-term survival rates of his restorations because of dental hygiene. And I would like to remind you to write in comments your tips and tricks. How do you motivate your patients for complex hygiene manipulations, let's say, like this? And the winner will have free of charge masterclass about technical aspects of tooth preparations. So now you can see a few angles from other views, and here is final X-ray. Actually, this is CT scan after 6 months, and you can see that there is a bone regeneration. So basically the process is in healing. That is another proof that conservative endodontic treatment can give us really good results in proper approach in some clinical cases. Okay, so I would like to thank you one more time that you are with us. I would like to remind you to subscribe, to sign up to our YouTube channel, okay, to switch on the notification. And I would like also to say, if somebody didn't see our previous series about BG dental cases, so here you can see the link to our playlist, and there are 6 more videos that you can see, and I'm pretty sure that you may find a lot of tips and tricks that will be really useful in your daily basis and absolutely free of charge. My name is Belograd, and I was really happy to share with you my clinical case, and see you next time. Bye-bye.